Good evening, everybody, and thank you for joining us for tonight's part 3 of our Women's Health and Arthritis session. This one is Healthy Living. My name is Jessica Barak, and I am the Executive Director for the Arthritis Foundation, Illinois. Just a few quick housekeeping notes. Everybody in the session is currently muted. If you'd like to ask a question, during the session, you have a Q&A chat box at the bottom of your screen. You can type in your questions there, and we will address them to the panelists throughout the course of the session. I'm going to introduce our panelists. First is Dr. Kelly Barella. Dr. Barella has been a dedicated faculty member at the University of Alabama at Birmingham, UAB School of Nursing since 2012, and currently serves as an assistant professor and interim assistant dean for graduate clinical education, MSN. She is a recognized expert in women's health with extensive experience in both clinical practice and academic leadership. In addition to her academic role, Dr. Barella maintains a faculty practice at the same facility where she previously worked as a full-time as a women's health nurse practitioner before transitioning to academia. Her practice focuses on providing comprehensive care to underserved women in the Birmingham, Alabama area, and she is deeply committed to improving healthcare access and ensuring that care plans align with patients' financial resources and psychosocial needs. Dr. Barella also serves on the board of directors for the National Association of Nurse Practitioners in Women's Health, where she plays a key role in shaping national policy, education, and practice standards for women's health nurse practitioners across the country. Her leadership in both clinical and professional settings continue to drive advancements in women's healthcare and nurse practitioner education. We also have with us Dr. Erin Arnold. Dr. Arnold is a board-certified leading expert in the field of rheumatology, pioneering an aggressive, comprehensive approach to patient care, emphasizing a unique diagnostic and treatment regimen focused on remission of disease. She is a graduate of the University of Illinois at Champaign-Urbana and received her medical degree from the University of Pennsylvania School of Medicine. Dr. Arnold completed her residency at the University of Chicago and rheumatology fellowship at the University of California, Los Angeles. She is the first American rheumatologist fellowship trained in diagnostic and interventional musculoskeletal ultrasound. She has also developed a unique accredited ultrasound exam that diagnoses inflammatory and crystal-induced arthritis and follows the patient's response to therapy. She completed a 3-year term as a member of the American College of Rheumatology Board of Directors and Rheumatology Research Foundation Board of Directors. She served as an American College of Rheumatology liaison to the Arthritis Foundation and the American College of Radiation. So thank you to our panelists today. And before we get into the Q&A portion of our session tonight, we do have some opening remarks from Representative Camille Lilly of Illinois' 78th District. Representative Lilly is a lifelong resident of Chicago's Greater West Side. She has a bachelor's degree in management from Drake University, master's degree in healthcare administration from Oklahoma University, Northwestern University's Kellogg's Executive MBA, and she serves on the boards of Westside Health Authority, Columbus Park Advisory Council, and Chicago Park District. So we'll hear some welcoming words from Representative Lilly now.
Hello, I'm State Representative Camille Lilly, and I'm honored to join you all today for the discussion on women's health and to talk about the tools that can be used to ensure you, as arthritis patients, are getting the best care possible here in Illinois. Often we are caring for our family members and loved ones. Many of us forget to take care of our own health and make it a priority. Managing a chronic condition has so many challenges, and as women, there are additional aspects of our health that we must consider. That is, it is critical that we work collaboratively with our healthcare providers to make sure everyone on our care team is informed and on the same page. Improving health outcomes have always been a passion for me, both personally and in my role as a state legislator, which is why I sponsored the Illinois Healthcare and Human Service Reform Act. This legislation took sweeping action to address health inequities and obstacles, while establishing new programs, increasing transparency, oversight, and training, and created a community health worker program. Lucky, here in Illinois, you have a great team of legislators and organizations advocating to make sure we all receive the care we need and deserve. Thank you to the Arthritis Foundation and the Oregon for bringing us together to talk about steps female arthritis patients in this state can take to optimize their health and resources that are available to support their health journey. Thank you.
Wonderful. So let's move into our panel Q&A. Dr. Barella, I'm going to direct the first question to you, but Dr. Arnold, feel free to jump in as well. Can you start out by giving us some general recommendations that you have for creating a good relationship between patients and healthcare providers?
Sure. So I think that really the best way to create a great relationship, the most essential thing I think is just open communication. We're here to help you, and the only way we can help you is if we really can get a good understanding of what's going on with you. So, it's important to let us know and to trust us with that information so that we can help to provide you with the best care possible with what's going on with you. So the more we know about you, in other words, if you are coming to see me and you are someone who suffers from rheumatoid arthritis, knowing that history, knowing what seems to make things worse for you, your symptoms worse, what makes things better can help me to help you to live a fuller, happier life. I think the most important thing is just open communication, a really good communication channel between the provider and the patient.
Wonderful. Dr. Arnold, did you want to add anything?
Yeah, I would agree with that. I think Dr. Barella's spot on. The only thing that I would add is that I think it's really important to come to your visit with a new physician or a new provider, or a return visit, always a little bit prepared. Maybe spend a few minutes before the visit, or even if you have the luxury of a little bit more time, getting yourself organized. Because I think it's really important when you're face to face with that individual to be assured that you're getting all of your questions answered. I think that that enhances the communication that occurs between the physician and the patient, or the nurse practitioner and the patient, and also helps to build that trust. And so I think if you can do a little bit of preparation, those always seem to be the office visits for me that are the most productive, where we really can kind of get to the bottom of what some of the patient's concerns are and how I, as their physician or the staff that works with me, can best address those concerns.
Do you have any recommendations for how and when to connect? A patient should connect with their healthcare provider?
Sure. I mean, this is it's a fabulous topic for us to have conversations about. I think that this is a very unique time in healthcare. It's a unique time, in my opinion, in our whole country. But we're feeling some of the waves from what's happening around us within healthcare. And I think one of the things that I consistently hear from patients is how difficult communication can be. Often you'll have the opportunity to work with your physicians over a portal, which which is, I believe, how the majority of us really do enjoy communicating, because there's documentation then in your chart of the conversation that has occurred, so we can reference back to it. But really spending the time when you're crafting those communications can also be very useful. Again, making sure that you're sort of organized in your thoughts so that you get all of your questions answered. Reaching out to your physician or provider on a regular daily basis, probably not a great idea. And certainly not calling regularly. Also giving the individual time to respond to your message. I would say 24 to 48 hours really is an adequate period of time. Certainly, if you're having an emergency and can't get immediately in touch with someone, then going to the emergency room is going to be the most appropriate. But not sending multiple messages during the day through a portal also, I think, can be very helpful.
Good advice. Thank you. Dr. Barella, did you have anything you wanted to add to that?
Yeah, I agree with everything that she said. I think, for women's health, our guidelines change all the time. And we really start seeing we see women from adolescence, from the beginning when they start their periods, if they need to come in to see us, all the way through geriatrics, through menopause. Um, Pelvic exams, we really don't start those until after someone is 21 years old. But we still want to see you. So if there's issues that you're having, like with your cycle, and if it's affecting your other health conditions, then we would definitely want to see you, before then. It's great to establish care, because I think what happens a lot of times is that patients don't have an established primary care physician or an established place where they're going, and then they want to come when they have a problem and they can't get in. I think that's the biggest thing. So I think going ahead and establishing a relationship with a provider, so that when you do have a problem, you have access to care. It can sometimes take. I know here in Alabama, I'm in Alabama, I'm completely different, but I know here for us and for my friends, if I I, for example, missed my primary care appointment this month because I had something that came up that I couldn't not do, and it's going to be August before I can get back in. So if I had a real issue, that's the hard part. And then I think that's when people start to utilize the ER for something other than what the ER is really intended to be. And that drives up your cost because you're having to pay for, a cost of an ER. So I think just, go ahead and make those connections before you really need those connections. So that, we can help you when you do have an issue and you're not having to wait months and months to get in to be seen.
Thank you. Dr. Arnold, we'll start with you on this question. Do you have recommendations for specific action items or a checklist of items to regularly discuss with the healthcare provider or team? And what recommendations do you have for helping patients coordinate communication between primary care providers and specialists on their team?
Okay, I think that these are some really fabulous things for us to kind of discuss here this evening. I always emphasize to patients that they really are the central portion of the communication. And so we encourage them when they're in the office visit with myself and the women who work with me. We spend a lot of time creating a plan at the end of their visit that then I ask them to share with the other physicians who are taking care of them. We certainly communicate that through faxes, but I think sometimes maybe that doesn't get reviewed in as great of detail as if the patient brings those documents with them. We encourage the patients to keep copies of their records and to keep them organized, especially for more complicated patients. And just to capture again something that Dr. Barella mentioned, we also ask people to make their follow-up visits with us when they're leaving the office, not waiting and calling in when they know what their schedule is going to be, but actually to make a visit that can always get changed around, but so that we know that we have that follow-up in place, and for them to also understand why the follow-up's being made in a 3-month period or in a 6-month period, and what are the expectations for those visits. So, for example, if you are a patient who's been started on a new medication, is the expectation for the visit that you're going to have a conversation about how you've responded to the therapy and how is that response going to be assessed? In our practice, we ask our patients to come ahead of time to have laboratory tests done and appropriate imaging studies if we're looking for inflammation. So you heard Jessica refer to the ultrasound exam we do. So we'll often have people come ahead of time so that when they sit with us at the visit, we are optimizing our time together. We are problem solving together. We are using objective pieces of data to try to make decisions about how they're responding to therapy, and then also listening to how they think they're responding. Pain in arthritis patients is very complicated and multifactorial. And so while many of the medicines we use to treat rheumatoid arthritis and psoriatic arthritis and the inflammatory arthritides really are geared towards inflammation, that doesn't always translate into pain depending on the stage that a patient is in their disease. So I think really having a good understanding of what's the purpose of the next visit, how are we going to make that assessment together, and then what are other concerns you have? I always talk to the patient about what are things they really have control over and how will that impact their response to therapy and their care. So we spend a lot of time in the visits talking about what are some vitamins they should be considering taking. What are things that they should think about eating or avoid eating? What about activity? Increasingly, there's more data that's showing us that for arthritis patients, it's really important to have vigorous exercise as a part of your regular routine, that in fact, that probably helps to reduce your inflammation. And we all know that when you're more active during the day and exercising and setting aside time for that, that you're also going to sleep better. So those are also concerns that you might have. How are you sleeping? What are you eating? What are other things you're doing to try to kind of take control of your arthritis? And being ready to have those types of conversations and knowing how your response to therapy is going to be assessed, I think can really make it so that you optimize, again, the time that you have face to face with the physician or the NP or the PA who's there working with you. That's a lot of information that I just gave. And you could translate it into other illnesses like our lupus patients. How are they going to assess that you're responding to therapy? Can you keep track of the amount of flares you're having so that that's useful data that you can provide to the physician or provider when you're in the visit face to face? Really optimizing. I want to be problem solving with my patients when we're sitting face to face. I'm not interested in doing that over the portal, over the phone after the visit's been completed. And I think if you can have that information ready for the visit, it really is helpful.
Great. Additional thoughts on that, Dr. Barella?
No, I think she did it. She did a great job covering it.
Okay. Um, Dr. Arnold, we will stick with you for another question to start off with. Are there specific issues or symptoms that those with arthritis should take note of to bring up with their gynecologist or OB?
This is a great question, and I'm sure Dr. Barella will provide more information as just kind of some more background information for this. One of the things we really spend a lot of time talking about now, especially in women who are perimenopausal or just postmenopausal, is what would be the impact of hormones on some of their symptoms. So fatigue, weight gain, and frankly, pain. Often it's the missing piece when we've been covering everything else. So I always talk to patients about following regularly. I always sit down and say, who are the people you really need to be seeing? You need to see your internist, you need to see me, you need to see your dermatologist, you need to see your OB/GYN, and you need to see your eye doctor, right? Those are for everybody kind of the standard people we want involved in their care. And the time that is spent with the OB/GYN, we really want that to be about women's health issues. Are they being safe in their intimate interactions that they have? Would hormone therapy be helpful for them? What are they using as far as contraception if they are still somebody who would be childbearing age? How can we work together to make sure that they can have the best outcomes if they do decide to have children? And then bone density, often rheumatologists will manage that in place of an OBGYN or in conjunction with them. So that's another thing we encourage people to talk about. But I think really making sure that women are being safe, and that they have the resources that they need to be hormonally healthy.
Dr. Burrell, I'm going to flip that question for you.
Okay.
And are there gynecological issues that are important for those with arthritis to bring up to their rheumatologist?
Yeah, so absolutely. So the loss of estrogen, especially in those perimenopausal and menopausal women, can actually affect women's arthritis depending on the type of arthritis they have. So for example, like with um rheumatoid arthritis, you may notice that your symptoms are worsening with the loss of estrogen. Like Dr. Arnold said, people who have arthritis and are on different types of medication can already have some issues with bone loss. I'm so sorry if you could hear my dogs. They all of a sudden started, so just let me know.
We
Um,
can't. We're
Okay,
good.
good. May already be dealing with issues with bone loss or be at a risk for bone loss. And then you top that with the loss of estrogen that you have during menopause, which also contributes to bone loss. Women really need estrogen in order to maintain our bone health. And so once you start losing that estrogen, you become at risk again for bone issues. There's also other things if you're not menopausal and you're just a reproductive age woman who is interested in birth control and you decide that you want to go on something like Depo-Provera because it's easy. You take an injection every 3 months. We also know there's a black box warning on that medication as well, that if it's used for long periods of time can lead to bone loss. We think that it's the majority of it is reversible, but that's something that you need, they need to be aware of, because if you're going to be put on, another medication that may contribute to bone loss, then that may speed up that process. Heart disease in women is probably the number one killer in women. And women with arthritis, they may be at more of a risk for heart disease. As you lose that estrogen, you also become at risk for heart disease. So these are all things that you would want to bring up. And then again, if you are reproductive age and you're thinking about having a baby, you're ready to start having children, talking with your rheumatologist about that, because there might be certain medications that you're taking that would not be good for you to be taking while you're pregnant. So really, I think thinking about, when you're going to the different physicians that you're going to, always thinking about us working together as a team to best take care of you. So for example, if you were coming to see me, I may not know that you're also seeing Dr. Arnold for arthritis. So letting us know that, here's my thought on this side of my health care. I'm thinking that I want to become pregnant. I'm thinking about, we're thinking about starting a family. What do I need to do? Are the medications that I'm taking safe? Are there alternatives if they aren't? Is there something else we can do? Is there a certain amount of time I should wait before we start trying to have a family? Something that I need to, get out of my system. Think of us as working together to best take care of you. And the best way for us to do that is to kind of fill us in on what's going on in all the other, the parts. Like Dr. Arnold was saying, you think about the big things that the big physicians and healthcare providers that you go and see. Just like your dentist, you would never think that pregnancy would affect your dental hygiene, but it does. And so knowing all of this together, we can really help to best take care of you. So really no question is stupid. There's not anything that you can tell us that we are going to think is dumb. There's not too much information to give us. I think the more information that you can give us, the better. And that way we can get you on medications if we need to that are going to be the safest for you. We can guide you in the direction that you need to go with your health care to keep you safe. And if you're trying to get pregnant, keep the baby safe as well.
Yeah, and I just want to emphasize again that really the central role that the patient should be empowered to play is you're your advocate.
Mhm.
Even in a healthcare system that's fully integrated, you're still there to make sure that you are communicating everything. Don't make assumptions that people know what's going on, even in a fully integrated system. It's not worth it. And so if everything can come through you and be centralized through you, that's much safer. I always say to my childbearing age patients that, I'm the third wheel. I'm the other person who's involved in this pregnancy. And communicating about when you're planning on getting pregnant, what do we do with medications, and when you are pregnant, when, the delivery, I say, I'm in line, hopefully, right before like the grandparents get to hear. So we all want to be engaged and involved so that that goes smoothly. But again, the person who really should take control and have that responsibility is really you, the patient.
Yeah, I completely agree. You are the most important part of the team. You really hold all the information. Um, and so we want to hear from you.
Great.
I'll just one more thing to say, because I think it's just, again, I think it's a really important thing to keep emphasizing. A lot of female patients say to me, that because I got on medicines early, like people can't really tell how bad my arthritis is and how much I suffer. And I think having conversations about that with multiple providers is really important. And specifically within a women's health environment, having real honest conversations about intimacy is really important. Because, if you're tired and you're in pain, sometimes that's the last thing you're really interested in. And you have a spouse who, might feel not understand that. And so just being able to engage the OBGYN in those types of conversations as well, I think is really important as another support system for you.
And I'm sorry, I know this question this is a good one. Um, you're absolutely right. And your OBGYN should be talking to you about your sexual health and should be finding out about the number of partners you have and all of the things that you would think would be uncomfortable conversations. We should be asking those questions so we can best take care of you. So, and we want you to tell us, be honest with us, let us know. Like Dr. Arnold was saying, I have so many patients who come in that say that they are having some difficulties with sexual health and that their partners are upset and frustrated, frankly, not really understanding. I think most partners that I have, most patients that I have will tell me that their partners automatically think that there's something else going on in the relationship. And that brings on more stress, which, by the way, makes it much more difficult for you to be intimate when you are stressed. So that's a huge, big, important part of life. And so we want to be able to help you with that. And like she was saying, if you're in pain, if there's issues, if there's something that, that we can do to make that part of your life easier, that's what we're here for. And so we should be talking to you about that. And I would encourage you, if you have a provider who isn't wanting to discuss these things with you, that, consider maybe seeing someone else. I know that sounds really harsh, but that's a huge part of life is your sexual health. And so, you need to feel like you can go and openly talk about this so that because again, that's a part of your life.
Listen, for men, it's sometimes the top part of their life. So
It
women
is right,
often
the
push
only
that
part.
aside. So engage in these conversations. It's
Right.
important, right? Don't wait
Exactly.
for someone to ask you, please engage.
Thank you for all that advice. We do have a question in the Q&A box, and I think it goes back to Dr. Arnold when you were talking a little bit about diet and vitamins and exercise. So the question is, would you recommend that RA patients consider Ozempic, or I'm not going to pronounce this right, Wegovy,
We'll go.
weight loss. I'm assuming these are weight loss medications. So what are your thoughts on those types of medications for patients or individuals with rheumatoid arthritis or other types of arthritis?
Sure. I mean, listen, this is an evolving science. It's a very interesting time right now in weight loss. I think one of the most important things for us to have conversations about is just how to be engaged with food in a healthy way. And I think the thing that we all have to acknowledge that in this country, although we have a lot of exposure to food, much of the food that we are exposed to is unhealthy, and that many of us have an unhealthy relationship with food. So I think that it is inappropriate to have conversations or initiate medication for weight loss without addressing also how you engage with and relate to food and exercise. Weight is very, very important in the treatment of patients with inflammatory arthritis. In fact, for the last decade, we've had very good data that shows that if patients carry extra weight with rheumatoid arthritis, that they actually respond less well to medications, in part because of the inflammation that adipose cells or fat cells create. And the additional stress that that puts on their response to the medication and the capabilities of the medication. The addition of these medications for patients who have actively addressed the relationship that they have with food and the choices that they make around food have been life-changing. And there is data that shows that patients with inflammatory arthritis have less inflammation when they successfully lose weight with these medications. These medications, though, are not risk-free. And when there was a shortage of these medications, they became very available through compounding, which is actually in the weight loss arena, very controversial, the compounded medications. And so I think that these are real medications. They have the potential for real side effects. One of the long-term side effects that we worry about in our arthritis patients is muscle wasting, which we are seeing now. And the other thing, frankly, that we worry about is malnutrition, because if people have not addressed how to eat in a healthy manner and are losing weight because they're on these medications, that means that they can keep on eating nutrient poor foods while losing weight. And so it's not good for their body. So I think the answer to that question is, with the appropriate supervision and the right expectations and the understanding that it really should be a comprehensive approach to weight loss. They're great medications, and we use them in our practice. About 5 years ago, one of the PAs that I worked with, I encouraged her to actually get certified and educated in the use of not just the newer injectable medications, but some of our oldies but goodies like metformin and phentermine and stuff like that. And we have a lot of success, but we also have really high expectations and ask patients to engage in a pretty comprehensive program that involves meeting with our physical therapist, working on food cataloging and journaling, and really addressing these bigger issues that I think are at the root of a lot of people's weight gain. That's a very long answer. I think they're great meds, but nothing is for free. And we're learning more and more about them in both a positive way and maybe not so positive way.
That's great feedback. A question has come in the Q&A that's for Dr. Barella, somebody who was with us in the first session of the series. She said, we learned that some women with RA, their symptoms may flare up around their menstrual cycle or ovulation time. She says, I have never been told that before, and it was a bit of a light bulb moment. I am definitely one of those people. Are there any specific birth control medications you would recommend for limiting the number of periods you have each year?
Yeah, absolutely. So some of our long-term or long acting birth controls, like our LARCs, like for example, an IUD and the Nexplanon, which is the implant that goes in the arm. Oftentimes those will prevent you from having a period. You won't have a period, and some women who do have very little. But any of the medications like birth control pills, the patches, the rings can all be used continuously. So it was interesting to me several years ago when um, we they started introducing seasonal and seasonique that were marketed so that you would only have 4 periods in a year. You would do continuous birth control pills for just 3 months and then just have, that amount of those cycles in a year. You don't have to have a cycle at all, ever. And you don't need seasonal or seasonique to do it. You just do it with a regular birth control pill. So you just take them continuously. And I actually did that myself. Because I didn't want to have a period. Right. Who wants to have and I have some patients who do. I have some patients that say, I need to see it. And I understand that if you need to see it, you need to see it. But for my patients who have conditions like endometriosis, really horrible cramping, or for patients who have really, bad bleeding issues, I will use a continuous birth control pill. So again, any of the monophasic. So that's really most of the pills that are on the market. If you've ever heard of like the orthotricyclines and the ones that are the triphasic drugs, you can do it with them, but it doesn't work as well. But doing it continuously, the thing that really worries patients, I think, is that they wonder, well, all of that's just going to build up inside me. Where is that going to go? And actually, there is nothing there. So instead of you going through that hormonal roller coaster that you go through each month during that whole cycle, it really keeps you at more of a steady state. So you're not building up a lining that you need to bleed away. The other thing that worries patients is that then that's going to cause them some issues with infertility. And there hasn't been anything that has shown that any of that would cause an issue with infertility. Someone somewhere along the way, and I think it was in school, and I think this is correct, told me that that when birth control pills were first invented, they were invented or created by men. And the reason that you had that withdrawal bleed at the end, that last, if you've ever taken a pack of pills, that last 7 days is usually just placebo, and they're there just to keep you taking them, just to keep you where you're not forgetting by the time next Sunday rolls around that you need one. And that the reason that they did that was because it would mimic a woman's natural cycle, because they felt like if it didn't, they wouldn't buy them. And so they really weren't doing us any favors, because we really don't want to have one anyway. So I would say that would be my suggestion. If you don't have a contraindication, that would be the only thing. So talking with your provider to be sure that you don't have any contraindications to take in some type of hormonal medication, like you've got a clotting disorder. And by that, I don't mean like the clots that you have with your menstrual period, like one in your leg. Or if you've ever had one in your lung. If you don't have migraines with aura, you don't have uncontrolled high blood pressure, you have never had cancer before that was an estrogen dependent cancer like breast cancer, then that would be my recommendation for you. And that what it does again is it just keeps you from going through that cycle of hormones every month. And that's what really starts to cause some of those issues that you have, the cramping and all of those issues. It just keeps it at a steady state, and you can wear white pants every day of the year. That's the other blessing.
Amen, sister. I heard the same thing. I listened to this is about a decade ago, because I don't know if he's alive anymore, but the gentleman actually who created birth control. And they said that they did the break so people got their period to get adoption. They wanted women to agree to it, and they wanted it just to seem like their regular cycles without the risk of getting pregnant. So you are spot on.
That's fascinating.
Mm-hmm.
Okay. If there are no more questions in the chat box, I'll go back to our agenda. But just as a reminder, if anybody who's attending does have questions, please put them in the chat box, the Q&A. So Dr. Arnold, are there trends you're seeing in patient questions and concerns that you want to address?
I think that we have seen a lot of conversation. So the last 5 and 6 years since 2020 have really been an interesting time for all of us. But with COVID, really we spent a lot of our time having conversations about was, and understanding was appropriateness of vaccination and when vaccination should occur and what to do with medications regarding vaccination. And I feel like that has become pretty well established now within the rheumatology field, and there's many documents that have been created, and most rheumatologists are now very well equipped to give patients appropriate advice on vaccination. And my thing that I say to all my patients is really the only thing we've accomplished within healthcare is actually vaccination. We haven't cured cancer, we haven't cured any of our arthritides, but we've prevented illnesses or eradicated illnesses with vaccination. So it's nice to have that information in place to be able to give people the best advice. More recently, we are having to have more conversations about measles and people's concerns regarding that. And so I think, again, I love it because I think that people are paying attention to make sure that they can stay as healthy as they can stay and want to be as up to date with what's appropriate. And so that is definitely something that I would encourage people to keep reaching out to their primary care physicians about, as well as their rheumatologists, just to get advice on that. And then the other thing that we hear all the time from patients is just having more of an interest in what are things like I talked about at the very beginning that they have control over that they can do that will allow them maybe ultimately not to require medication if they do it first, or to at least allow them to use the least amount of medication possible. And so I would encourage you to really continue to engage in conversations with your provider about things like exercise and diet and sleep. Sleep disorders are huge within the rheumatology community and severely underdiagnosed. And so we send people all the time to go get sleep studies to make sure that they really are getting good consolidated sleep and not having issues with sleep apnea. You don't have to be, somebody with a large neck to suffer from sleep apnea. I have a mild form of it. So, but it can, right, exactly. But it can really be disruptive from a pain standpoint and an arthritis standpoint. So we do hear people wanting to have more conversations about what are other things that they can do to optimize their response to therapy and ultimately their outcomes, which I think is really, really wonderful.
I have a question in the Q&A that somewhat ties into that, and the question is, could an unhealthy lifestyle be a cause for RA?
Absolutely. So we know that people with listen, it would be impossible to really be able to tell each patient why they develop their disease. And although instinctually we want to know that, why is this happening to me? Why at this time in my life? And there's so many possible reasons. But one of the things that we see is unhealthy lifestyle. So we know with obesity, there's a greater risk of developing inflammatory arthritis. We know that poor dentition can also be a direct cause for inflammatory arthritis. And in fact, the heart disease that's also associated with inflammatory arthritis. And we know smoking puts you at incredible risk for developing an inflammatory arthritis, especially in individuals who have primary relatives who suffer from these illnesses. So if you have a father or a mother or a sister, sibling that suffers from one of these illnesses, you're at greater risk because of unhealthy lifestyle choices.
One more question in the Q&A. If you would prefer not to answer this, I understand, and I can ask this person to connect with me offline. But the question is, are you able to recommend a good rheumatologist in the Chicago downtown area? I know your office, your practice is located in Skokie, which is not downtown. Like I said,
No.
if you'd prefer not to offer recommendations, I understand, and
So I think a rheumatologist is a doctor that you have a long-term relationship with, and it's often difficult. It's hard for me to recommend without knowing the patient a specific physician. There are a lot of different rheumatologists who I think are very good, but they're very different from each other in the city. And you have an abundance of them. It's also a question of what's your tolerance for working within a larger healthcare system, right? So Northwestern is there. Loyola has a spectacular rheumatology department, and frankly, Rush has, I think, one of the best rheumatology departments as well. So you have a lot of larger organizations if you are able to tolerate negotiating those types of health systems. And then there are plenty of physicians that are in small private practice groups that are in the city. And so I think some of it is getting on their websites, kind of seeing what their philosophy is, and then maybe taking the time to set up a couple of appointments and meet with people and see how you connect. It's pretty obvious when I sit with somebody who I don't think is going to really enjoy working with me. It's obvious to them and to me right from the very beginning. And so I think that, that will become apparent to you even if you look at their website.
I'm going to ask my own question on that note because I can. As for both of you, does it bother you if a patient chooses to go to a different provider that they, for whatever reason, but if they feel like you're not the right fit, how do you as a provider feel about that?
Dr. Barella, you want to go first with that?
Sure. No, that doesn't bother me at all because ultimately what I want is for you to get the best care that you can get. And if that's not with me, then that doesn't bother me at all. Also, I think patients are often afraid of getting a second opinion, that that's going to hurt my feelings. No, absolutely not. We want you to do that if you're able to get a second opinion. So I welcome all of those things because most importantly is the care of my patients. And if they feel like they need something that I'm not able to provide them, then I would want them, again, you are your advocate. You are your best advocate. And I would say, yeah, go for it.
Exactly,
Absolutely.
100%. And I always say to people that if a physician gets angry at you for getting a second opinion, that's a physician you shouldn't continue to work with. In fact, the only time I get a little frustrated is when people don't ask who they should get a second opinion from, because it's not just an opinion for you. Like Dr. Barella said, I want to know too. So if I'm gonna have a sense that there are better people to give us a second opinion about this type of arthritis versus this type of arthritis. And I might actually ask you to leave the state to get an opinion about a certain type of illness that you have, rather than seeing people that are within the Chicagoland area. So I think it's an important conversation to have, and a good physician slash provider shouldn't be offended by that at all. And no, I'm never, my feelings are not hurt when someone wants to leave.
I appreciate your honesty, and do think for maybe women in particular, there's this sense of like, oh, I feel badly, I don't want to hurt their feelings, and it's good to hear directly from both of you that it's not hurting your feelings, and in fact, you encourage it. So I will take those words to heart, as I hope our attendees will.
And I'll just add one more thing. I think as Dr. Arnold was saying, I think most women, at least for me and the women that I take care of and women that I know personally, just like your rheumatologist is someone you're going to have a long-standing relationship. I think your gynecologist is another one of those people. People don't really move around from them too very often. And so if you are working with someone who you're just not, you're not meshing, you need to go and that's what we want you to do. We don't want you to stay and feel like you're not getting the care that you need. That's a long standing relationship. Most of the time, we carry you all the way through, from menarche to menopause. So we want you to be in a place where you feel comfortable and you feel like you're getting the best care.
Wonderful.
Agree.
And I think this dovetails nicely into another question, which is, what is your advice for being an advocate for your health and dealing with gaslighting?
Well, I think, just like what we were saying, I think sometimes patients feel like maybe and this may be my opinion, but I think a lot of times not speaking up has to do with feeling like you're not smart in this area, for example, and you don't know best, and maybe the physician or the provider is the person who knows best. But then I've seen a lot of patients and again, have a lot of friends who have personally, gone and felt like they weren't heard. They come in with symptoms and sometimes, it gets put on maybe this is a psychological condition and really not a real pain that you're having. You know your body better than anybody does. And just because it's written in a book somewhere, or this is not written in a book somewhere, doesn't make that that what you're telling us isn't real. And so I say that too with side effects of drugs. I see that all the time. Patients come in and say, well, I lost my hair when I started taking this. And that's not something that's listed, but hey, it happened to you. So that could very well be the case. Let's take you off of that medication. Just you know yourself better than anybody, and nobody is going to take care of you like you. And so if you feel like you're not being heard, then I would say get up and run. You need to go and find somebody else who's going to really listen to what you're saying, listen to your symptoms, and, actually cares about trying to get to the bottom of what's going on with you.
I agree. So this is a real issue, especially for rheumatology patients. Women in pain are often dismissed. The number of people that come to my office as new patients that tell me they've been given a diagnosis of fibromyalgia, and I always say the same thing. I say, I agree, you have a vagina, right? We're going to start there because that's the people that right off the bat in pain get told that they have fibromyalgia. So it's really, really a relevant situation. So much of what we do in rheumatology is about stories. And if someone's not letting you tell your story, then you need to point that out to them. I learned a lot about this from the patients that I work with. And I learned about a situation where I wasn't hearing what someone was saying to me by a very brave patient who pointed that out to me. And she was right. I wasn't hearing what she was saying. It doesn't happen frequently, thank God, but it was very brave of her, and I was very receptive. So if you're working with a doctor who's not receptive when you say, wait a second, you're not hearing what I'm saying, or this symptom might not be common, but it's happening to me, then you do need to step back and consider finding a new person to work with. It's important for you to be heard. Only you can tell your story, and you need to make sure people are listening. Now, you don't have to come in like, guns ablazing, ready to go after the doctor. You need to come in with communication skills to make sure that they're hearing what you're saying and understanding, and that you're comfortable questioning if you don't think that they are. And I think that's just another way to build trust and a relationship with someone. But it's very, very prevalent for women, and especially women in pain. There are studies that show that if you bring someone with you, and most importantly, even if they're a total stranger, if you bring a white male with you into your visit, that you will have less of a chance of being gaslit. In fact, African American women are often gaslit the worst. But again, if they just grabbed a stranger out of the waiting room and brought them in with them, they would have an opportunity to experience probably a higher level of receptiveness and care. So I think it's just important to keep those things in mind. Again, some physicians have no idea that they're doing it, and they're not just men. Women do it all the time to other women, all the time. So it's an important thing to have a baseline understanding of, but also to make sure that you really feel like you're being heard.
We actually now have an abundance of questions in the
Uh-oh.
Q&A, and we have 4 of them, and we have 5 minutes left in our time. So please keep that in mind as I'm going to try to get through all of them. So the one that's most directly related to this topic, what about if you find things in your records that are not correct, such as it says you don't have alopecia, but you actually do, but you wear wigs? That question was never asked of you. This is just one example.
Correct it.
Yeah.
That's a
Speak up.
no-brainer. I mean, yes, speak up. We have people who review their records all the time and they'll say to me, why are you using this diagnosis, for example? And often I didn't have hand pain, I have hand stiffness. And I explain to them, well, number one, we want everything that we're doing to get paid for and for you not to have to pay for it, and help them understand why we'll choose different diagnoses. But if that part of your history is not in there and correct, then correct it.
Thank you. Okay, next, this is about a specific treatment. Does Cimzia work effectively for RA? When can you expect to see the results?
So Cimzia is a great medication for rheumatoid arthritis in some patients. In general, you should start to see a response to therapy within a 3-month period. That's what we're looking for, is response. Not maybe complete response, but trending in the right direction. And again, this is where it's important to have some objective piece of data. Are you following an inflammatory ultrasound study? Are you following blood work, et cetera? But you should start to see a response within a 3-month period.
Um, Next up, do you have, and this is for either, do you have any advice for women approaching menopause and living with arthritis?
Go for it, Dr. Barella.
Again, I would just say, as you're getting closer to menopause, paying attention to your symptoms. Let us know when you're coming in. I do have patients that, again, you should have a really good narrative, I guess, basically when you come in you should have a great conversation. The thing that helps me the most whenever I see a patient is the history that I get from them. The exam is great, but hearing your story is even better. So I'm going to want to know what your bleeding is like. Have there been any changes? And let us know, even if you think it's a blessing. For example, I have patients all the time that say, well, I don't have a period, but like once every 6 months. I begin to start worrying about other things after that. I start to think about other conditions that may happen as a result of you not having a period. So even though you may not think it's something worthy of discussing, let us know, because it very well could be. And again, letting us know, paying attention to your symptoms. Are they getting worse at certain times of the month? Can you tell that? Because that's one of the questions that I'm going to ask you, is if you notice that you're having pain at different parts of the month. Is it coming before your period? Is it coming after your period? Those kinds of things. And again, just communicating with both your rheumatologist and your gynecologist on what's going on. You're entering into menopause. What is this going to mean, as far as my medications go? Or, what changes might I expect? Everybody kind of wants to know what's going to happen next. Nobody likes that, that anticipation of something and not knowing what it is. And so just kind of having an idea of what the next steps might be will help kind of relax you as you move into that period of menopause. Again, I'm sorry for the dog.
Quite all right. Um, Dr. Arnold, what are your thoughts on functional and integrative medicine treatment for RA?
So I am a big proponent of a comprehensive approach to rheumatologic care, not one in exclusion of another. I think that integrative specialists can be very helpful in some situations, but I do think that they should work in collaboration with a rheumatologist, not in exclusion. I think there are a lot of interventions that there is really more risk associated with them than potential for benefit. And again, having a collaborative relationship between the integrative specialist and the rheumatologist that's communicating through you is really important.
Well, we are at the end of our time together. So I want to, I mean, we could talk for much longer probably, but we did say we would keep this to an hour, and I will stick to that. So I want to thank both of you, Dr. Arnold and Dr. Barella, for your support and participation. Somebody put it in the Q&A box. Thank you all so much. And that echoes, I think, what our participants are experiencing. We will be sending out post webinar email with some supplemental information and a survey to give us feedback on what your thoughts were on the series. So we would appreciate if you gave us those thoughts and completed the survey. I also would like to thank Organon for their support of this entire webinar series, as well as for their ongoing commitment to advancing and supporting women's health policy. So with that, I thank you all for joining us. I hope that you have taken away information that will be helpful for you in your healthcare journey. I know I have. And again, thank you for being here. Thank you for your support, and have a good evening.